All right, with that bit of background on both GERD as well as Enteryx, let's go on to talk about why these problems happened. One of our big challenges is to focus on what is really important. And once again, this case is illustrative of many of the differences between medical device versus drug clinical trials. And let me begin by saying that medical device clinical trials are both fundamentally as well as philosophically different than drug trials. Fundamentally and philosophically different. Fundamentally, what I mean there is in terms of mechanism or design. In other words, in drug clinical trials, for example, we design them in phase 1, phase 2, phase 3, and so on and so on. In medical device clinical trials, we don't have any such thing. To illustrate, whenever I hear someone talking in the context of a medical device clinical trial, phase 1, phase 2, phase 3, and so on, right away I know they don't know what the heck they're talking about, because that simply does not exist in a medical device clinical trial. Philosophically different, that is what we're going to get into here. So medical device clinical trials are fundamentally as well as philosophically different than drug trials. And as I started to say, one of our challenges is to focus on what is really important. There are a lot of important aspects of the Enteryx case. It's one of my many favorite case studies to talk about, and I'm just going to mention a couple of reasons why. First of all, in drug and biologic clinical trials, most people would agree that the number of patients is very important. In other words, the more patients that we use, the better. If we have a few tens of patients, that's really not very good in a drug trial. A few hundred patients, that's okay. A few thousands of patients, that's better. Or, oh boy, a few tens of thousands of patients, that would be even the best. Merck not long ago finished a clinical trial, 70,000 patients in a single clinical trial. But when you think about it, that's absolutely nuts. And in a topic of another discussion, which is my vision of the future of pharmacogenomics or personalized medicine, I describe in some detail how we can do a clinical trial for a new drug, that is a new molecular entity or an NME, not with hundreds or thousands or tens of thousands of patients as we've been doing in the past, but with a few dozen or perhaps just 1 dozen, just 12 patients in an NME clinical trial. Is it possible? It's not possible based on the way we've been doing things and the way we've been thinking about things in the past. But if we're willing to think differently, it is very possible. That's the subject of another discussion. So in this particular case, in the world of drugs and also biologics, the more patients, the better. But in reality, let me just point out, it's not nearly so simple either. On the drug side of the world, and that's beyond the scope of this particular discussion, a lot of people think that simply increasing the number, or in statistics what we call the statistical power of the trial, is a good thing. But here is a not so hypothetical example. If we have two drug clinical trials, let's say one that has 200 patients and the other that has 2,000 patients, many people would say that the 2,000 patient trial would be more realistic because it is higher powered. Absolutely not, at least not necessarily. If what? If we use the same inclusion and exclusion criteria. If we use the same inclusion and exclusion criteria between the 200 patient trial versus the 2,000 patient trial, can we really conclude that the 2,000 patient trial is better, in other words, more reflective of reality? Simply put, absolutely not. Many, if not most, clinical trials are biased before they even begin, and there's many ways that we can bias or influence the results of clinical trials. By controlling the inclusion and exclusion criteria, that is just one of many. But once again, that's more of a drug issue. We're going to be focusing on medical devices here. So in medical device clinical trials, what is even more important than the number of patients? The number of patients in medical device clinical trials is really not that important, not like it is in drugs. What is more important is the number of doctors. And let me illustrate with a couple of examples. The number of doctors is equally or oftentimes more important than the number of patients in a medical device clinical trial. And it's not even quite so simple as that. Let's see how. So let's consider two not so hypothetical but similar clinical trial scenarios. In scenario A, we have a trial for a new endoscopy-based medical device using 100 patients and 5 physicians. By the way, 100 patients in a medical device clinical trial is pretty good size. It's not very big with drugs, but in medical device clinical trials, it's pretty good size. Let's compare that to scenario B, where we have a new endoscopy-based device where we use 100 patients and 50 physicians. Would you expect the results of these two trials to be the same? Absolutely not. Why? Because medical device efficacy is a very strong function of the skill level of the user. Let me illustrate with a very simple example. I can take one catheter and put it in one physician's hands and get wonderful results. I can take exactly the same catheter and put it into another physician's hands and get abysmal results. Simply put, medical device efficacy is a strong function of the skill level of the user. And this is especially true in certain medical device areas, for example, in endoscopy, which is what we're talking about here, in laparoscopy, and in catheter-based technologies. In endoscopy, laparoscopy, and catheter-based technologies, efficacy is a very strong function of the skill level of the user. But life in the medical device world is not even as simple as that. Let's take this a step further. Let's consider two similar clinical trial scenarios. These are iterations of scenario B that we just saw a moment ago. So I will call the first one scenario B1. Here we have a clinical trial for a new endoscopy-based device using 100 patients and 50 physicians, where all 50 physicians come from the top medical institutions and therefore have the most hands-on experience. And let's compare that to scenario B2, a clinical trial of a new endoscopy-based medical device using 100 patients and 50 physicians, where the 50 physicians are chosen from a mix of the top medical institutions as well as some community-based hospitals. The question is, would you expect the results of these two clinical trials to be the same? In short, absolutely not. Even though the numbers are exactly the same, the number of patients and the number of physicians are exactly the same, therefore your statistical analysis would be exactly the same, we would not expect the results of these two trials to be the same. As I mentioned earlier, there are many ways that we can bias or influence the results of a clinical trial. One of the best ways that we can influence the results of a medical device clinical trial is by what I call cherry picking the physicians. And let me explain what I mean. When we enroll physicians in clinical trials, we typically try to enroll the most experienced, the most hands-on physicians, that is, the ones that have the most experience with our products or our competitors' products. Why? Because we all know that efficacy is a strong function of the skill level of the user. And obviously in a medical device clinical trial, we want to have the highest efficacy rate as we can. So as a result, we cherry pick the physicians from the best medical institutions, i.e. B1, and avoid using the what I call average docs. And because the good clinical practices, or GCPs, for medical device clinical trials are essentially a carbon copy of what they are for drug trials, and this issue is not a drug issue. In other words, on the drug side of the world, I can give a patient a pill, or another person can give them a pill, or a third person can give them a pill, and that patient is going to respond to that pill or not, but it has nothing to do with the skill level that we have of giving them the pill. Because the GCPs for devices are essentially a carbon copy as they are for drugs, this issue is simply not addressed. So for many years, I have advocated putting into the GCPs for devices a requirement that we need to use some number of what I call average docs in our clinical trials. Of course, nobody wants to be referred to as an average doc, but some number of average docs in our clinical trials. Of course, industry is adamantly against this. Why? Because they would argue that if we include some number of average docs in our clinical trial, that would bring our efficacy rates down, which I would agree. I would say, yes, you are more likely to have lower efficacy rates. But I would respond by saying, although your efficacy rates are going to be lower, they're also going to be more realistic. And now we get to the age-old philosophical question, and that is, should clinical trials be realistic? Simply put, many, if not most, of the clinical trials that we do today, not just in the world of medical devices, but including in the world of medical devices, they are simply not realistic of the real world. That is, they are not realistic of the way we actually practice medicine in the real world. So, should clinical trials be required to be realistic? I will leave that as a rhetorical question for now. Finishing this up from a mathematical perspective, let me just emphasize that scenario B1 and B2 are exactly the same. In other words, the number of patients and the number of physicians are exactly the same. However, the two trials are not the same and would likely not yield the same results for the reasons that we just described. Let's also note that while it is possible to quantify the level of experience, in other words, to take into account in a statistical or mathematical analysis the level of experience, this is much easier said than done. In other words, it's not simply the number of years a physician has been in practice or the number of procedures they have actually done. After all, it's possible for two physicians that have been practicing for exactly the same period of time and have done exactly the same number of procedures, and yet one physician is simply better at it than the other. So suffice it to say, precisely quantifying the level of experience, although not entirely impossible, is very difficult to do. Clinical trial design, not just in the medical device world, but this is a great example of in the medical device world. Clinical trial design is as much of an art, perhaps even more, than it is a science. Certainly something to think about. But clinical trial design is not the focus of this particular discussion.